Hey, good afternoon, everyone. Welcome to the HL7 DaVinci Community Roundtable. Today's session is the latest take on CMS 0062P and real-world DaVinci implementations of CMS 0057F, highlighting PDex and member attribution. And my name is Casey Thompson. I'm the program coordinator for the DaVinci project, and it is my pleasure to open today's Community Roundtable. So before we get started, I just need to remind all of us that we engage in these forums under HL7's antitrust policies to ensure appropriate collaboration and information sharing. Today, we're pleased to bring you the latest take on CMS 0062P and real-world DaVinci implementations of CMS 0057, highlighting PDex and member attribution with Denise St. Clair, with the HL7 DaVinci Project PMO and Vice President, Health Policy and Interoperability at Global Alliant, Inc., Mark Scrimshire, the HL7 Project PDex Implementation Guide Lead and Chief Interoperability and Innovation Officer at OnyxHealth, Michael Taylor, Product Manager at Availity, and the moderator, Alex Goss, the Program Manager for HL7 DaVinci Project and Senior Consultant at Point of Care Partners. Now, we will post the recording of today's webinar and slides on DaVinci's video presentations page in Confluence, and DaVinci's communication lead, Leslie Amoros, will be posting links in the chat box to assist with locating that page and other resources you may find of interest. So we ask that you use the question feature, the Q&A box, to submit your questions, as we've limited the chat feature for us to push key details to you and to enable you to download the chat box so you can save those links. We've also muted lines to aid in our recording quality, and we sincerely appreciate your survey feedback solicited at the conclusion of the webinar or at the point in which you depart the webinar. Now, our community roundtables occur each month in the last week of the month. Our next session is June 24th, and registration details will be posted on the DaVinci calendar, and there's also a link on this slide to all of our previous community roundtable recordings. Upcoming industry events include AHIP 2026, June 8th through 10th in Las Vegas, Nevada, the WEDI Summer Forum, August 10th through 11th in Chicago and virtual. And then HL7 events include HL7 FHIR Dev Days, June 15th through the 18th in Minneapolis, Minnesota, and the CMS HL7 FHIR Connect-a-thon, which is virtual, July 14th through the 16th. Links to all of those events are available on this slide. Okay, let's run through a few program updates. So we'll start with a quick review of our 2026 program priorities. This year, we will continue advancing our core functions with a strong emphasis on supporting our implementers, both directly and through our industry partners. We'll be putting significant effort into expanding our piloting activities, strengthening implementer engagement, and promoting shared learning across the community. These activities are essential to ensuring real-world success. We also plan to explore new and improved methods for engaging stakeholders in the implementation guide development process. Alongside that, we hope to develop a rubric to help us assess investments in IG development and determine adoption readiness. This will give us a more structured way to prioritize and understand where our resources can make the biggest difference. Our work will continue to involve close coordination with all of our industry and federal partners, and it's important that we remain responsive to relevant policy opportunities like 0062 as they arise. In addition, we want to continue elevating the awareness of FHIR and collaborating to help the community better understand the value of FHIR and the meaningful progress being made through DaVinci Implementation Guide development and piloting. Now, there are resources listed on this slide that you may find useful, including a link to our DaVinci in Action page, where you can see who's implemented various DaVinci guides to date, our DaVinci LinkedIn page to hear about everything going on at DaVinci, and our YouTube channel with recent recordings along with our industry statements and updates. Now, this slide shows where all of our DaVinci implementation guides currently sit in terms of maturity in their STU phases. And then there have been some updates I want to share with you on the next slide. So first, we've had a lot of movement on the burden reduction side. We've officially published several of our implementation guides in March, including coverage requirements discovery known as CRD, documentation templates and rules known as DTR, and prior authorization support known as PAS. On March 20th, PCT also published their technical correction IG update. And we're moving fast on the PDex side of the house. There's an STU update you'll hear more about today related to provider access, which recently concluded a formal 2-week peer review on April 24th. And next steps include ticket resolution and submission of a formal publication request. So we look forward to bringing you an update once this is published. Risk adjustment is also planning an STU update in May or June, which includes new operations, simplifying measure reports and remarks, and updating guidance so data can be submitted with a standard post request. So we look forward to bringing you that update very soon. And more information about these updates and links to the newly published guides can be found on this slide. And just to note, there's a full list of all of our Da Vinci use case calls and meeting times in the appendix of this deck. So I encourage you to take a look at that and get involved where you can. And you can find all of our calls and meeting information at the HL7 Conference Call Center at hl7.org and add the calls directly to your calendar from there. Okay, now we will move to the latest take on CMS 0062 and the real-world Da Vinci implementations of CMS 0057, and we'll start with Denise. As a final reminder, please use the Q&A option to submit your questions so that we can keep the chat open for information sharing. Okay, let's dive in. Denise?
Thank you so much, Casey. Hi, everyone. So what we're going to do today is take an opportunity to talk to you a little bit about where we are as the Da Vinci organization with our response to the CMS 0062 proposed rule. Still in the process of working through our response, but we can give you a little bit of a flavor of where we are and where the membership in the community is landing on their positions on proposals of interest. Next slide. So I will point out that this is high-level review of the rule. This is not every proposal in RFI in the rule. What I'm going to focus on today are those things that membership has indicated are of greatest interest for commenting on as Da Vinci to CMS, ONC, and HHS on the proposals in this rule. So the first proposal that we are addressing is the one the rule is named after. So this is electronic prior authorization for drugs. So as you know, in CMS 0057, it was finalized that for impacted payers, Medicare Advantage organization, Medicaid and CHIP fee-for-service and managed care organizations, as well as issuers on the federally facilitated exchanges, for those impacted payers, they had to set up FHIR-based prior authorization APIs using CRD, DTR, and PAS with CDEX for additional information. And that was required for non-drugs items and services. So what this proposed rule is doing is bringing in drugs to add to the non-drugs items and services that are already required for all impacted payers. And so the proposal is for drugs covered under the medical benefit, use the FHIR-based APIs, so use CRD, DTR, and PAS, and for drugs under the pharmacy benefit, leverage the NCPDP standards, and specifically the real-time pharmacy benefit, prior authorization check, and the prior authorization request and response script standards. And the requirement is that this should be, or this would be required as of October 1, 2027, if finalized as proposed. And generally speaking, the Da Vinci membership support this bifurcated approach to incorporating drugs into the electronic prior authorization, appreciating that the NCPDP script standards are well in use for pharmacy benefit and that the FHIR-based APIs can work well to support medical benefit proposals. The other piece that is very interesting in this rule is that those implementation guides that were previously required under previous rule, or sorry, previously recommended under previous rulemaking are now being proposed to be required under this rule. And this impacts all previously finalized APIs. So the provider access API, the patient access API, payer-to-payer API, prior authorization API are all impacted by this proposal. And the compliance date would be as of the publication of the final rule, so that current unexpired IGs are required and expire on January 1, 2028. And then on January 1, 2028, the current versions are replaced by the updated versions indicated in the rule. And so, as you know, in 0057, you had the initial versions here on the slide. So V2 of the Karen IG, V2.0.1 of Da Vinci US Drug Formulary, 1.1 of Plan Net, and then the prior authorization IGs, it was the 2.0.1 versions that were finalized as highly recommended in 0057. Since then, we've had particularly for the prior authorization IGs, we've had the 2.1 versions, and most recently, the 2.2 versions have just been published, and those are what are included in the rule as the most current versions that would become required on January 1, 2028. A note that there is an ONC rider in this rule, which would therefore update 170.215 with these IGs, and CMS would then point to that. And there is an alternate proposal that suggests expiring everything the day the rule is published and really pushing folks to that 2.2 version of the prior authorization IGs and the most current versions indicated in the rule to start. That would make it really, really hard, considering that we know a lot of folks are leveraging 2.0, they're leveraging 2.1, and they're making their way to the 2.2 IGs if we're using the prior authorization IGs as an example. So what the position of the Da Vinci community as of now is one, revisit the term expired. That means something different in HL7. So in HL7, when a IG is expired, it is still available for use. It's just not being updated any longer. But as the term is used in the rule, expired means don't use it anymore. So that can be a little bit confusing when looking at the rule from a HL7 perspective versus the CMS regulatory perspective. So that's one thing the community noted, is be careful about that. And then the other is to really clarify, particularly for electronic prior authorization or EPA, if those 2.1 versions are available as unexpired versions through January 1, 2028, to be compliant with CMS 0057, to be compliant with CERT compliance, which relates if folks are playing along and looking at the IPPS 2027 rule, there is an opportunity to get bonus points if you use prior authorization IGs that for certified health IT. Of course, the current rulemaking for certification for health ID for the prior authorization modules, which is voluntary at this time, does also call out the 2.0 versions of the prior authorization IGs. And so one of the things that we are indicating is it's really important to clarify what the glide path is from currently unexpired IGs to expired IGs. And so what we know is that today we have a couple of versions that are in use in the ecosystem, particularly if we're looking at the prior authorization IGs. It is the named IGs, the 2.0.1, as well as the 2.1 versions, and that we appreciate that per these proposals, the 2.2 versions would be required on January 1, 2028. So what we're asking is for clarification that folks could use any of the unexpired versions, 2.0, 2.1, until January 1, 2028, be in compliance with all things, and then starting on January 1, 2028, everyone move to 2.2 and further. So clarity around that, make sure everybody knows exactly what the rules of the road are, exactly which IGs are available to use until January 1, 2028. We also suggest that they consider looking at PDex 2.2, which was not out when the proposed rule was finalized, but is imminent, and you'll hear more about that soon in today's webinar. But there are some particular advances in PDex 2.2, particularly around member match and treatment relationships out of a group context, a concept that could be really valuable. So the Da Vinci community is suggesting a look at that version of PDex. But then another key consideration here is that the rule proposes essentially leveraging the standard version advancement process, or SVAP, for helping to advance versions of these IGs once they are required, so that the community doesn't have to wait for rulemaking to be able to use the next available version of the IG. Currently, the SVAP process happens on an annual cadence. And as we all know, IGs may update at an off-cycle timeline. So one of the recommendations of the community is to evaluate CMS and ONC how to leverage SVAP at the time when one of these IGs would be ready for a new version, as opposed to waiting for that sort of next annual cadence of the SVAP process as it is implemented today. So something to think about there, just a way to ensure that the IGs can advance in their normal work group process and consensus-based process on the timeline that makes sense for the community and that works with testing and all the things that happen to advance an IG version with balloting, et cetera. And that when a new version is ready, it is ready for the community to use as soon as humanly possible. So that's what we're focusing on there. Then there's a proposal to recommend a few IGs that were previously not recommended. So those IGs previously recommended in former rulemaking are now being proposed to be required, and 3 new IGs not specifically named previously are now being proposed to be recommended. And the 3 that are being recommended are the HL7 FHIR Da Vinci Member Attribution List IG, or ATR List IG, which you'll also hear about more today. The prior authorization and that's specifically called out for the Provider Access API in particular. For the prior authorization API, they are recommending CDEX specifically for attachments, and UDAP via the Fast Security IG. So the Da Vinci community does support the proposal to recommend these IGs, and you'll hear more about use cases where ATR is in use. And we have previously noted that CDEX is called out in the PAS IG. So there is an expectation that CDEX is available to support the prior authorization process as it's noted in the PAS IG. So calling that out specifically makes sense. And then for UDAP, the community does note that there's great value in UDAP when used to support networked transactions. That's really where UDAP shines. But indicate that it would be valuable to have that be one tool in the authentication and authorization toolkit, because for point-to-point, it's still, there are other opportunities to be leveraged, and UDAP really does work best when it's a networked transaction. So have it as one tool in the toolkit, but make sure the other tools that are there are also available. So that is where the community is landing on that. And we do note that it's important to realize that there are a number of IGs that are referenced in the required and recommended IGs, particularly HREX is a great example, just one example, but a great example of a referenced IG that isn't called out by name, and the community doesn't feel it needs to be called out by name, but just important to note that there are a number of referenced IGs within the recommended and required IGs, and calling that out so that it's a known quantity that the expectation would be you'd use the referenced IGs as well as appropriate and indicated in the implementation guides now proposed to be required and recommended. There are quite a few proposals around prior authorization metrics. So the first set of proposals is looking to update those metrics that were finalized in 0057. And again, these are all for impacted payers, Medicare Advantage, Medicaid managed care, and fee-for-service, and then for the issuers on the federally facilitated exchanges. These are to be publicly reported. They do some clarifying on the reporting timeline. So for instance, it was, by March 15th, you have to report because the calendar year is January 1 to December 31st. You get a few months and then you report the data. That makes perfect sense for, say, a MA plan or an issuer on the exchanges. It didn't make as much sense for the Medicaid and CHIP plans. And so they're proposing to make it no later than 90 days after the end of a rating period. So it just makes more sense with the plan cycle. And then indicating that it should be by program and plan type for Medicaid and CHIP managed care and fee-for-service entities. And all impacted payers, another update to the 0057 metrics is that in addition to reporting the percent of the currently finalized metrics, report the count. Because obviously 5% of 10 is very different than 5% of 10,000. So having that context could be helpful. And folks need that to calculate the percent, so they figured it should be pretty easy to share. They're also adding 6 new metrics for prior authorization for non-drug items and services. And the idea would be for this to be compliant with the effective date of the rule to be reported in the following year. And generally speaking, the Da Vinci community supports clarifying the reporting periods and reporting the numeric count and the new metrics. The new metrics for prior authorization for all drugs is another proposal for prior authorization metrics. So obviously, if the rule is adding prior authorization for drugs within the rule, it's also saying then we should report metrics on those prior authorizations. It is important to note it is for all drugs, excluding Part D drugs for MAPD plans. And of course, just like all the other metrics, these would be posted publicly. There is a proposal to add 15 new metrics for MA organizations and QHP issuers. Basically the same metrics for those two plan types, just slightly different wording to make sense for how the plan type works. And then for state Medicare fee for service and state Medicaid and CHIP fee for service and state Medicaid managed care and CHIP managed care entities, they are proposing 6 metrics. And so those, again, would be initial reporting in 2028 with data from 2027. And generally speaking, the Da Vinci community supports adding these new metrics for drugs. They do request clarification on how to count cases where past transactions aren't required. And so and this is true for both the new metrics under 0057 and the new metrics for prior authorization for all drugs, because one of the values of adding the FHIR-based APIs would be to necessarily always need a prior authorization transaction, so not always need to get to PAT. Using CRD or DTR, you discover that enough information has been shared to give you the okay to move forward or to indicate you don't need the prior authorization. So can we capture the value and the burden reduction of those actions? So that's one question. And the community is also suggesting capturing an additional metric, which is the method by which the prior authorization was received, making sure that we can really understand when the APIs are coming into play and how using the API impacts the outcome of that prior authorization and the timing of such. So that's where the Da Vinci community is currently landing on metrics. There is a proposal to report payer API endpoints and associated information for CMS to publish. So this is a proposal for impacted payers to report API endpoints for each of the required interoperability APIs. for impacted payers to report the URLs for specific required documentation, specifically FHIR capability statements, authorization and authentication protocols and implementation details, and API registration information. And the idea would be for CMS to get this information to publish in a centralized location that could be easily discoverable by developers. There's an alternative proposal in the rule to leverage the National Directory for Healthcare, the NDH implementation guide, specifically the endpoint profile, to be able to share this information with CMS. The compliance date would be no later than 60 days after the effective date of the rule, and no later than 60 days you'd have to send this information for new coverage for new payers. And if there's a change, you'd have to update that with CMS within a week, and you'd have to verify the data every 12 months. And ultimately, the Da Vinci community appreciates the value of reporting endpoints and making this URL information available in a central location, so it's easily discoverable. The community does suggest payers also make endpoints and URLs discoverable so that it's the opportunity of working directly with the payer and finding it, and/or finding it at the national level through the central location. There is a strong desire to make sure that whatever is proposed is truly implementable, particularly when we're looking at reporting the URLs, because there's the need to be able to support multiple URLs per API. And when you're talking about on the payer side, a URL potentially for each plan type. And currently the NDHIG does not accommodate that multiple URLs for the same payer entity or the necessary metadata for URL per URL for sharing the information that's required through this proposal. HREX IG does take into account this needed level of detail. So one of the things that the community is pointing out is that you need to look a little bit more closely at the NDHIG and appreciate that the rule does note there could be multiple URLs per API, but also appreciating that sort of by plan type piece and looking at the complexity that HREX RG allows, and understanding that any sort of final proposal on this would have to sort of mirror that complexity and potentially consider HREX for that purpose. There is a proposal to update the 0057 provisions and require information about prior authorizations for both non-drugs items and services and drugs being included in the patient access and provider access APIs, and to include new information about prior authorization for drugs in the payer-to-payer API. So basically now we're doing these prior authorizations for drugs as well as non-drug items and services. So make all of that information available through the existing APIs by October 1st, 2027. And in general, the community supports making that information available via the APIs, but does note that some of this information is not currently maintained by the payers, particularly for drugs where they're working with a third party or a PBM to manage that information. And so one of the things the community noted is that they're working with their third-party partners and their PBMs now to figure out how to get that data so that they have it available to share timely through the other APIs. And that also relates to metrics too, making sure they have the data so they could report the metrics on the drug prior authorizations. For API usage metrics, there is a proposal to add some additional information and also, again, clarify the reporting period and the level of reporting and who people are reporting metrics to based on impacted payer type. So again, for Medicaid and CHIP managed care, indicating definitely report to the state and within 90 days at the end of the rating period. So again, makes sense to use the rating period, not the year. For QHP issuers on the FFEs, report annually as part of their QHP certification program at the issuer level. And they're proposing that all impacted payers report annually at the contract level, state, plan, and program, or issuer level, depending on plan type. So MA at the contract level, Medicare and CHIP fee-for-service at the state level, Medicaid and CHIP managed care at the plan and program level, QHP issuer at the issuer level. That they report this annually aggregated and de-identified data. They don't specify a form or manner at this time. We do indicate it would be good to do that sooner than later so folks are ready for this reporting. And they do also indicate some additional metrics that they would like reported for the patient access API and new metrics for provider access, payer to payer, and prior authorization API metrics. So essentially, in earlier rulemaking, there were metrics for how is the patient access API being used, and now I want to make sure that they're also capturing usage metrics for all of the required interoperability APIs. This would be beginning in 2028 for data from 2027. So the Da Vinci community does support clarifying who metrics are reported to and on what annual cycle by impacted payer type. And the community suggested an additional metric. They suggested the number and percent of patients who have opted out of the provider access API data exchange, because that is an opt-out option. So it'd be great to know how many folks have done that. There's a proposal to remove drug formulary data from the provider access and payer-to-payer APIs, effective with the publication of the rule. And generally, the community support this proposal and note that CMS should consider, however, making formula information open, like provider directory information. The IG supports that. So this is something where you could technically make formulary information openly available as people are shopping for plans. It was one of the intents of the original IG, just like they do for provider directory, make that available. People can see which doctors are available to me under this plan, which formulary composition is available to me under this plan without having to go to a bunch of different payer sites or portals. So that's one suggestion the community is making, but overall supports the proposal. There is also a proposal for impacted payers to update the provider directory API denial and discontinuation policies to align more with the other API policies. It was a little bit different in the previous rulemaking. You didn't have to quite shut off access to the provider directory API at the same time for the same reasons as the other APIs, and this is just aligning everything. So the community is in support of this proposal. Huge piece of this puzzle is moving away from the impacted payers. So not just the Medicare Advantage organizations, Medicaid and CHIP managed care and fee for service and QHP issuers on the qualified or on the federally facilitated exchanges. This now moves to HIPAA. And so this is everyone, every covered entity under HIPAA. And so these proposals that we're talking about now impact a much larger group of folks, and therefore it's important to kind of put those different buckets into perspective. So this would be all providers, payers, and clearinghouses who are covered entities under HIPAA. And the rule proposes to define prior authorization on FHIR under HIPAA, specifically for the verification and authorization transaction. They have two proposals, a primary and alternative. Primary is to have it defined as an inquiry from a healthcare provider to health plan to obtain authorization for care and a response for that authorization. Alternatively, it's basically also use FHIR for referral transactions. So it wouldn't just be for authorization, but also for referral. And the Da Vinci community does support the alternative proposal to leverage FHIR for both authorization and referrals, as the IG support both. The second proposal is to update the eligibility for a health plan transaction. And that is the name of the transaction under HIPAA. And the rule proposes that this would be applicable only when used to determine when prior authorization is required. And it would be for inquiries from a healthcare provider to a health plan to obtain benefit information, including eligibility to receive care, coverage of care, and copays and deductibles the response from the health plan would be to a healthcare provider about that eligibility increase. So really this is to support determining whether a prior authorization is required, and the community does support this under HIPAA FHIR. There are specific standards which are also proposed to update HIPAA so that the FHIR standard for prior authorization transactions would become a HIPAA standard. And again, this impacts everybody, providers, plans, and clearinghouses. And the idea would be to replace the X12278 referral and authorization with the base FHIR, as well as CRD, DTR, and PAS, to replace the X12-270-271 when related to prior authorization with the core FHIR and CRD. And then finally, to add on the next slide, CDEX as an IG for referral and prior authorization attachments. There isn't currently a prior authorization attachment standard finalized under HIPAA. The compliance date would be 24 months from the final rule. Effective date, 36 months for small health plans. So generally speaking, the Da Vinci community supports the proposal to replace the 270-278 with the proposed FHIR IGs and the 270-271 eligibility for health plan for prior authorization with CRD to support determining a prior authorization request is needed, and also supporting the inclusion of CDEX. We do also support not adopting operating rules for these new FHIR-based transactions, as FHIR already has everything within the IGs, and there's no need to sort of duplicate the operating rules concept with FHIR, as that's already just taken into consideration. Finally, there are 5 RFIs in the rule. There are 2 in particular that we have responses for today. We are evaluating another, but the 2 that we have been talking through are the electronic event notifications for value-based care and care coordination, and improving implementation of payer application programming interface technology. For electronic event notification, the community notes that the HL7 Da Vinci unsolicited notification IG might be something to consider. It supports FHIR queries for more timely information. So the community is noting that, a lot of the messaging, ADT messaging going back and forth can not necessarily always get there as timely as it could. And that the content of the message may be not quite what is needed on the receiving end. So the thought process was, if you consider the Da Vinci unsolicited notification IG, perhaps there could be a situation where you're able to, in a targeted way, query for and or get subscriptions for a patient on the very specific pieces of information necessary at those key moments of transition within care and care coordination. So the community is suggesting an evaluation of that IG. And then for improving implementation of payer application programming interface technology, one of the things the RFI asks are, what are some of the things that are most needed to support success for payers leveraging APIs on FHIR? And the community agrees it is the need to support comprehensive end-to-end testing. And there are a couple of ways the Da Vinci community feels that the regulators support that. One is supporting testing real-world scenarios with comprehensive longitudinal and realistic synthetic data, as there are tons of data available and the ability to create really strong synthetic data from federal data sets. So considering that as something that could be provided to the community, as well as a national testing sandbox. So folks can really do that true end-to-end testing of all of these APIs with real-world endpoints and users. And then the other big piece of this RFI is around payer system certification. This was also something that was in previous RFIs and rulemaking, which Da Vinci has previously commented on. So similarly, the community feels that it's important to clarify a few things before moving to payer certification, appreciating that certification can ensure nice organized, scalable implementation, which is a very, very good thing. But one of the pieces of information that the community is asking for clarification is, what does it mean to certify a payer system? So on the provider side, it's, for instance, the EHR that is certified or certifiable, where on the payer side, the question is, is it just commercial products that can be used by multiple payers? A number of payers indicated that they are working with internal systems that they've just augmented to support the APIs. So would that be something that could be subject to certification? Of course, certification is all voluntary at this time, but just a question around, is it an internal system that could be certified, or is it really just those commercial products? But again, seeing value of making sure that everyone is using products that accomplish the goals of the regulations. Another piece of the certification puzzle for payers is making sure that certification would be really for the most relevant data classes. There are a lot of pieces of information in currently required IGs potentially, even if you look at, say, US Core, that a payer may not have. But there are other pieces that, of course, they would absolutely have. So thinking about that when thinking about certification. So much as we could right-size certification, generally speaking, for both providers and payers, it's good to make sure that if certification is considered, that it's really right-sized for the data that payers have and the use cases they're using. So that is a very quick tour of all the proposals that the Da Vinci community is currently considering or responding to by that June 15th deadline. So Leslie, back to you.
I think we're going to turn it over to Mark now.
Casey, not Leslie.
Okay, thanks, Denise. There's a lot for people to chew on there. So that was a really, I know you crammed a lot of information into a very short space of time. So let me maybe talk a bit about a couple of things. If we want to go on to the next slide, Casey, I'm going to cover PDex STU, Payer Data Exchange, our STU 2.2. So where are we in that journey? And then explain, because of that version, a little bit about the bulk API support that we have in PDex, particularly as that then relates to what we're calling Provider Access version 2. We probably should come up with a really cool name for that, but everybody seems to recognize we have a new version. And then I also want to touch on, in relation to some of that, we'll also touch on some of the things happening where we've leveraged the attribution IG. I know that was mentioned earlier. And then there is some interesting things going on around PlanNet and Provider Directory, particularly in relation to CMS Plan Finder. So we'll give you a couple of things on that front. And I believe there's going to be some testing that we're going to be doing at the CMS Connectathon on that PlanNet front. So let's dive into it. Let's start with what is actually available in the PDex bulk APIs, right? We are taking the US core clinical data. So now that the current version is 6.1, the guide was actually implemented with support for 3.1.1, 6.1, and 7.0. So we're somewhat future-proofed if ONC decides to move US core forward. We also work with the Caronalites on their Blue Button project. So rather than develop a new version of a way to explain effectively a claim, we leverage the fact that the Karen Blue Button had done some great work, and we worked with them to have what we call a basic profile that redacts the financials from basically the Blue Button claim. So that's the EOB profile. So if you are already producing claims, many of you payers do that because you're covered by the CMS 9115 rule, it should be a relatively light lift to be able to then make that data available through the bulk APIs. And then what we did is also, since the PAS prior auth support IG utilizes the claim and claim response, that is actually the basis for the design of the original explanation of benefit profile in FHIR. And so there's a very close correlation with the fields between the EOB and a claim. And so we have actually worked with PAS so that we can take the PAS claim response and any of the additional extensions and basically be able to drop them into an EOB profile so that now we can take, that means we can exchange the prior auth decisions and the supporting clinical data. And so what will be happening is, yes, there will be data going into the patient access API. So we will see this prior authorization information being available to the patient, to the member. And that will be available through the patient access API. So we're seeing that expansion there. Obviously, as Denise was telling us, if the authorizations for drugs, if all of that goes through, becomes a finalized rule, that will largely follow the same sort of flow to come into these, what I'll just term generally the access APIs. So PDex is covering the patient, obviously a single request from a single member, being able to take the data that they want, put it into an app of their choice. What CMS 0057 did was basically say, let's add two other audiences to that. One is the provider. And I simplify that down to saying, it provides the capability for an in-network provider or a known provider to the payer to come knocking on the door and say, tell me what you know about my patient. And they would, as long as the member has not opted out, and the payer agrees there's a treatment relationship, they would be able to then retrieve that information. And they more or less get everything that would be in the patient access API, except for the claims would have had the financials redacted, okay? And so all of the structured information that supports a prior auth decision would potentially be available. So imagine if I was a GP, I'd sent a patient along for a referral to a specialist put in a prior auth request. They needed to provide supporting data. That gets a decision by the payer. Effectively, the referring provider could actually see that that member got an approval for a prior auth. So we're starting to see better flow of data around the industry. The other API that was added, again, these are both bulk APIs, is when we, as being very fickle people, we decide to move from one plan to another at the end of the year. So we go through our Medicare Advantage enrollment. We decide to pick a new plan. We'll be able to go to that plan and say, yes, I do want you to go and get my data. And there are good reasons you might want to do that, because maybe you want the plan to have access to the prior authorizations that have been approved so that they can be ready to take you on as a new member and see that you're getting the right services that are required. Now, there is a subtle difference here in the API ruling here in terms of the content, and that is that CMS has actually said that, and it's really driven by the timeline required for one payer to respond to another during enrollment, to basically say both the structured and the unstructured data should be available through the payer-to-payer API. So the question would be, how do you do that? In very simple terms, US Core includes a document reference. So effectively, you could have the unstructured documentation, think of it as a fax or an image from an X-ray, could be basically attached to a document reference and be exchanged through the standard FHIR protocols that we are putting in place with these bulk APIs. So there's the content of the payload that is typically in these bulk APIs. So the question is, how do you get to use them? So Casey, if we can go to the next slide, we'll start with how payer-to-payer works. Now, this is going to be basically unchanged in the STU 2.2 version. And it's really a two-stage process. The first thing is I'll call it the new plan and the old plan. Okay, so I go to my new plan and I say, yes, I want you to get my information. We designed this as a deterministic match function. So I am going to give my demographics information, my name, other bits and pieces like my date of birth. That's going to be the demographics. I'm going to give the payer my prior coverage information. So typically the information you would find on the coverage card, your subscriber or member number, maybe the URL of the payer. There is a bunch of information that is there that, if you think about it, when you go to get service at a provider, you provide that card, that somehow results in you getting an EOB from your payer. So they know how to match with that information. The other piece that we include, though, is effectively an authorization. So this covered entity, the new plan, has collected an agreement from the member that they want them to go get the data. So that covered entity can now bundle that up along with any other member coming from that same old payer, and send that across in basically doing a bulk member match. So this bulk operation takes a look at each of these bundles of data for the members and comes back with constructing either a matched group, so they're dynamically building a group of members that have that they found the match. There may be some that they don't have enough information. There is something they can't find that member number, whatever it is. Maybe it's a bad transcription. So that goes into a not matched group. But then there's a third category where the member may have said something like, just get my non-sensitive data. This was an option that was there in the 9115 rule. And so the old plan may be in a position of saying, I've got all of the data in my FHIR API, but I can't tell what's sensitive and what's not. So in that instance, a payer is going to fail safe. I'm not going to distribute information where I might release something I shouldn't. So they would put that member into a consent constraint group, and that bundle goes back to the new plan. And now the new plan can take that matched group, and they can use that as the driver to do the bulk Da Vinci data export. Now, this is an operation that's defined in the attribution IG. Again, one of the things we try and do in Da Vinci is to not try and do 3 different ways of doing the same thing. So we're actually using the same Da Vinci data export that is there in attribution. And so you simply call it with that particular matched group, and you would get back the data for those members that have joined you and said they want you to collect their data. So that 2-step process. So Casey, let's go on to the next slide, because I think we've got here provider access version 1. When we built this, we basically said that the payer is really responsible for determining the attribution, that's a loaded term, the treatment relationship. And so they would take their basically lists for each provider and build a list of all of the members that provider can see. Now, they would have to take into account the fact that the member can opt out. So they can provide effectively a negative consent. I do not want you sharing my data. And the plan would have to basically eliminate those people from the list, the group. And that forms a group resource in FHIR. And basically, the provider would come along, do the query against that group, and retrieve the data that they wanted. Now, that's all well and good, but there were 2 issues, and this is why we came up with version 2. The first is payers felt that there was going to be a lot of management overhead in managing those lists, which could be very, very large. You could literally have thousands of members against a given provider. And they're effectively dynamic because members could be moving around from one provider to another. So a lot of overhead in just keeping those lists up to date. And then think about it, the default action when an operation comes in using these bulk exports is basically, give me everything for everyone in the list. Well, that could be an enormous tax on the payer to serve up all of that data. And in fact, the provider typically doesn't want all of that. And so what we're actually finding today is that payers are still implementing version 1, and it does have a very good specific use, and it relates really back to the attribution IG, in that when you are engaging in value-based care contracts, you end up typically with a fixed list of members that are assigned to a provider. Now, that's a good use for the provider access version 1. Create that list and allow the provider to come in and query for all of those members. They're probably going to query for them, and maybe they're going to then do it every month, but they're going to say, give me everything for the month of April, and take all of that data. And then the following month, they said, give me everything for May. And so it does have a use, and that's why we're not actually withdrawing version 1. It's still there in the IG, and that was in version 2.1. So taking this feedback from the industry, if we go to version 2, if we go to the next slide, Casey, thank you. We're basically doing the same thing as in the payer-to-payer member match. So a provider could, for example, collect the current coverage from their member. They would typically be doing that at the front desk anyway, to see that they've got the coverage for that member. You've got their demographics, that would be their patient record. And we simply ask that the provider, since they're a covered entity, just provides a provider attestation of a treatment relationship. So it's really just noting that this provider believes they've got a treatment relationship with that member, and it's not forcing the provider to go and get the member to go and sign something. It's really just a statement, almost a pro forma, for the provider to complete that. That makes it a very, very similar transaction, as you can gather, to the pay-to-payer member match. So basically, the list goes in, and that could be the list of members I'm seeing tomorrow. And so it could be typically a very short, much shorter list. And the payer will go through the same process as they would with payer-to-payer and say, can I match this member, or don't I match, or is there an issue? Have they basically opted out of sharing data? And so perform that match function and hand back this identifier for that list of matched members, which you put into your Firestore as a payer. And now the provider comes in and does the same Da Vinci data export that they would have done in version 1, but now it's for a much smaller group. So it could be for like, hey, here's the 10 patients I'm seeing tomorrow. So it much more closely aligns with the typical workflow for payers and providers. So providers could decide also, one of the things we accounted for in the flexibility of the Da Vinci data export is we're not forcing the provider to take a fire hose of data. They could be very selective about the resources that they are interested in. So for example, if a provider focused on diabetes, they might just be interested in observations that had A1C readings. And you can construct a FHIR query that does exactly that. So you could actually pass in the instruction saying, give me the data for these members, and I'm interested in these particular FHIR resources. So the provider is in a position to avoid taking that fire hose of data. They can be as selective as they want. And so we built that capability. But at the basics, if the provider comes in and says, give me everything for everyone on the list, it's a much smaller list. It's a much smaller lift for payers. It avoids that effectively denial of service attack on your FHIR API. So that's why we implemented Provider Access version 2 in STU 2.2. So let's go on to the next slide, Casey. So let's cover, how does a payer determine the provider access response? We're still leaving the provider, with the payer, with the ability to filter out members. So we've used some examples. Maybe a payer has a list of, we'll call them gold-carded providers. You, as a payer, is saying, I'm not really going to try and second guess them because they do such a good job. And you may take a decision, a business rule that says, if I have one of those trusted providers that's gold carded, that gives me a name of a member and says they've got a treatment relationship, even if I've maybe not seen a claim from that particular payer and provider and member come through my system, I may still say, I want them to be able to have the data to be able to give that member the best service possible. Whereas if there is a new provider that you have got on your books and they come in claiming for an attestation, you may be more cautious and say, no, I want to see that some claims have come through to say, yes, there really is a treatment relationship. So we are still leaving capability for the payer. They're not just having to slavishly respond to every request that comes in from a provider. So particularly as we look forward to more of a networked aspect, there may be a step where the payer is needing to look and say, do I even know this provider? Are they in my network? Before they're just responding with a member match. So we're really trying to provide the building blocks for this to be used in a number of different ways as we go further into using these bulk APIs. So let's keep going. I know, conscious of time. So where are we with PDex? We went through a 2-week review. We've actually had some of the provider access version 2 tested at some of the recent connectathons. So we've actually had some real life testing going on. We've also seen that STU, the provider access version 1, is being used in production today. So that's all great news. What happened, we went through an STU update process. We put this out for a 2-week peer review, and we actually had over 50 tickets submitted that we have taken a look at. I've gone through reconciliation. I'm still finishing that up. And the intention is, since we now have approval from financial management, who's the sponsor of the IG, to actually move to publication. I'm just tidying up that the IG, making sure that the QA report is clean so I can go to the fire management group and ultimately to the technical steering committee and ask for publication. And I am racing to try and accomplish that before we get to the closure of the comment period for 062. So you can go and put in a proposal saying, please support PDex STU 2.2. So you have this flexibility of using provider access version 2. So all of that is in play right now. We're actively working on cleaning up the IG, really value all of the feedback that has come from the community in making that IG better. So that's where we stand today. Let's keep moving on because I want to leave time for Michael to come on. So PlanNet, what's happening there? We will be having a connectathon track because there is an increasing amount of interest in the PlanNet IG coming from CMS. The requirement around the CMS Plan Finder is going to be to publish information about your providers and organizations that are in network. The good news is if you've implemented the PlanNet STU, particularly the 1.2 version, it's been pretty stable, PlanNet has, you're in a very good position to be able to meet the CMS requirement, either by taking the resources that you've got in the FHIR API and putting them into basically NDJSON and publishing a manifest. But what you will find is there are certain fields that are probably not being populated by you at the moment. And we've actually produced a validator tool to help you work out what's missing. And we can certainly cover that. That will be covered at the CMS Connectathon. So the typical thing that's missing is this plan ID and contract number at the provider level. So being able to identify, CMS wants to be able to identify which providers are in which network, because when you're coming to pick a new plan, it's what you want. One of the things you want to know is my provider in network? It has a real impact financially on patients and members. So look at that. You need to look at where you are with your PlanNet data, but you're in a very good position if you have implemented PlanNet to be able to meet the CMS rule. I'll leave it there. Let's go on to the next slide. And so I want to actually hand over to Michael Taylor from Availity for him to give us a run through on some of the things they've been doing with implementing and maybe even a demo. Over to you, Michael.
Thanks, Mark. And hello, interoperators. I'm Michael Taylor. I'm a product manager at Availity, and I'm focused on peer-to-peer and provider access. So, what Availity's been doing for the past couple of years is we've been working on establishing a self-establishing network that's a self-establishing network-oriented connectivity solution uh, for CMS 0057 APIs. And we've been working with a cohort of payers for about 2 years. All of those are now live in a non-prod environment. Two of them have completed end-to-end testing, and they've done a bunch of positive and negative tests, including varying the actual clinical data within the payload. So a lot of interesting stuff happening over here. We've kept our focus on keeping our solution as consistent with this PDex spec as possible for maximum interoperability, with the idea that our solution is a intermediary that sits in front of another payer, and we proxy their requests to a network audience rather than point-to-point connections being established one at a time. So, with all that said, I said that it's a self-establishing network. The way that happens is when members consent to like a payer-to-payer exchange. That means that that payer now needs to go exchange with someone that they have not talked to yet. When that connection is established, now the whole network has the benefit of that connectivity instead of just one payer establishing one connection. So what am I going to demo today? I want to demo some of the PDex implementation that we've been working on. At HIMSS, I demonstrated the payer-to-payer singles flow. So today I'm going to go through the payer-to-payer bulk. I'll try to touch on some of the things that Mark had mentioned. And with that, I'll go ahead and share my screen. All right, so I'm going to show this without a really pretty user interface, but I'm going to walk you through everything so it's all right. What we're looking at right now is a program called Insomnia. You might be familiar with Postman. They are API testing tools. And to orient ourselves on the left, we've got tests that I can perform. In the middle, we've got the test I'm going to send, and on the right, we have the response. Now I want to orient you about what I'm talking to. So when I send a request, it's going to Availity's hub, and that hub is going to route to whatever pair I'm directing that request to. And for this purpose, I'm going to tell it to go to our mock pair service. So our router is going to route it to this other service as just the same as it would to any other pair, and that's the service that's going to be responding to me, but everything's going through our hub. Okay, so we've got the test bulk collection here on the left. I'm going to start with the authorization step. I've got my client and ID and secret populated, so I don't have to show it to you. There's not a whole lot of information in the token call, but when I do that, I get an access token. This access token, oh, here's something of note, is that I think this was about a year ago. I think it was between PDex 2 and PDex 2.1. Don't quote me on that, though. There was a shift of the member match in bulk, moving from a synchronous response to an asynchronous response. And that effectively, I'm going to show you what that means. So in a synchronous response, you get the response right in the body. When you have an asynchronous member match response, you send a member match request and you get back a status URL to check. This allows, if you've sent a request for a whole bunch of members, this gives the payer time to do all the member matching, to assemble the groups, and to respond back appropriately to the pair they're looking to. So let's go ahead and see what this looks like. I think I'll do the synchronous methodology since I just showed you asynchronous. So I did the authorization call. The sorry, there we go. This token right here is going to automatically be carrying over into the authorization header of this request. Within the request, there's all the information that Mark talked about. In a single request, obviously you'd only have a single patient. Here we've got a member bundle. We've got a patient with information about who their coverage to match is, who their coverage to link is, and their consent information. But unlike in a single member match, that bundle is repeated for each member that I'm sending this request for. And I got back a response with a bunch of groups. That group ID is going to be automatically pasted. Oh no, I'm going to have to copy the group ID. Apologies. So now I'm going to request a token for that group. I've now got that token. I can now move to the Vinci data export request. I need to paste that group ID here again. So you can see this is the FHIR URL. We're saying /group ID / Vinci data export. And it says no body returned because that status URL for the export is returned here. Go to the status step. Again, my access tokens are being automatically filled and everything. So this URL is the biggest new step on this step. So now I got back a list of files that's able to be downloaded, and I'll just pick the first one. Did I copy the whole URL? Yes, I did. Good. All right, so this is a really small file for demonstration purposes. So the data that I got back is very minimal, but you can see that we were able to query our mock payer service and get those responses back through our hub. And that's pretty much how our hub is oriented. Let me see what I've got for final remarks. Here's some lessons learned that we've gone through in 2026. Number one is that synchronous and asynchronous member match that I mentioned. Number two, just like Mark was talking about, provider access version 1 versus version 2 is a big change, but we think version 2 is a boon for all parties involved. So we recommend everybody to take a deep look at provider access version 2. And note that if you are watching this and you are a Blue Cross Blue Shield plan, you have additional considerations beyond just the CMS mandate for how you'll coordinate data throughout the association. So with that, I think I can wrap up and hand it back.
Awesome. Thanks for that, Michael. That was great. I think, Casey, I think I'm just on the board for just a couple of comments about what do we do, how do we go about implementing this? So I'm going to put my implementer hat on because we're implementing for many Medicaid plans and a whole host of payers out there. And we're still seeing payers now going through the RFP process and wanting to implement 0057 with not a lot of time left. And so people are very much thinking about, well, where do I start? What do I do first? So I'm going to give you a quick sort of 3 or 4 points. Well, A, get the contracts taken care of. You really need to start moving on this. This is now, it's very much a buy solution rather than build. There's a lot that you've seen, that example there that Michael and the Availity team have been working on for quite some time to provide all of the capabilities. So where do you start? Simple thing is start with the patient access API. If you haven't implemented that already, it's the basis for just about everything there. You've got your FHIR patient records, you've got all of the claims and clinical data. That then becomes the basis for actually being able to build your or implement your provider access and payer to payer. It's just different audiences utilizing more or less the same data. And if you get that underway, then you can go and take the time to really look at the real complexity that is in 0057, which is the prior authorization flow. Because for many plans, particularly the larger plans among you, you probably don't have one vendor. You may have multiple of them, and they may be for certain specialties. And so you need to have the time to go and work out with each of them as to what are they going to be supporting? Are they, for example, are you dealing with policy guidelines? And so you're implementing the DTR piece of the prior auth flow so that you can work out the handoffs that go down the prior authorization flow. Also, having got the FHIR access APIs in place, remember, you've got to catch all of the prior auth information supporting clinical data, and in the future, the pharmacy, the medication data, and be able to put that into the access APIs to be able to share across those 3 different audiences. So you can be working with your vendors in how you're going to get all of that data delivered to you, because you're under a time crunch to actually publish that data quickly. So there, I would say, in very simple terms, so we've got time for maybe some questions, is start with the patient access API. You can then add on provider access and payer to payer. You can take your prior authorization data, the decisions and supporting clinical data, and start to embed that into that access API. And with those out of the way, now you can really focus on getting the prior authorization APIs, the CRD, DTR, and PAS flows implemented. And if you're worried about getting all of that done, I would say go do CRD first, because that will allow you to respond to a provider as to whether they need a prior auth or not. That in itself is a tremendous advantage. The fact that they know that they don't need a prior auth means while they've got the patient in the room, they can move to the next step that they want to carry out. And so that's a tremendous benefit to both members and to providers. So with that, Casey, Alex, I think I will hand back to you.
Thank you, Mark. Please stay on screen. I'd love to ask you a question. I also would love if Michael would come back on screen, because I also have a question for him. So thank you, gentlemen. And for my first question, I want to ask Mark to unpack that response time consideration with the delegated vendor dynamic, because I do think, Mark, that this is one of the things that kind of is bubbling up in a lot of places, because there are a lot of pieces and parts that go into a payer system and enabling all the necessary data processing. And so if we think about this handoff and needing to get support, especially when you get into the lighter part of the process with utilization management, can you talk about any experiences that you've been having or observations you have from your client implementation engagements?
Yeah, we're actually talking with a payer that we are onboarding right now. They're based out of California, and California's market is somewhat different, and they have literally dozens of delegated providers that are performing that prior auth function. And so there the question is, where are the touch points? In that case, it may be that their platform that they've got, the providers will be utilizing a provider portal to be able to communicate with ultimately the sort of management system. And that then potentially provides that one point of contact for actually being able to acquire all of the data that we need to then publish. But yeah, it's a real challenge, I think, given the way there are the different components as to how do you piece this together and get the response with the basically plain English definition of why you may have denied a prior auth. I think it's going to be an area we're going to see a lot of movement over the next year as people really get to grips with it.
I think it's a really great point that we're learning as we're going, we're
Mm.
maturing and we're scaling. And when you start to get to really large scale exchanges, all kinds of those edge cases are going to come out, those complexities that reflect the business architecture choices, the business operations, communication choices, and the messaging that we go back. And I love how with PDex, you've already started to see some of that feedback and you've gotten to the 2.2 upgrade or version 2, I should really say, that you're advancing. And I just want to make a plug for folks that if you really, what Mark covered for you on the PDex V2 is of import, make a comment on that because although our
Mm.
federal colleagues proposed one version, they have very limited options for what they can adopt in a final version. And the only potential possible way for them to do something that they wasn't initially proposed is if there's a groundswell of support for that. Always good to have people comment on what they like. And if we can all work together to promote more consistent messaging back to our federal colleagues, that may help them move the needle through their general counsel reviews. So I want to move on to a question, if I may, to Michael. So thanks for coming on screen. There's a question that came in during your presentation on how does the new payer tell Availity, the old payer, to route the request to?
Yeah. Uh, so it's pretty simple. So in the PDex specification, whether you're talking about bulk or in the single member version, um, in the member match request body, there is a coverage to match and coverage to link resource. And there is a place for the payer identifier for that old coverage and a place for the payer identifier in the new coverage. So if you can populate it there, that will tell us where the message is intended to go. If you're not able to modify the body of your member match request, we can also support custom headers.
So work it out one-on-one or modify your header. Okay.
Yeah, it's Alex. It's typically there's a setup process in connecting, and so I would argue that probably a lot of payers can name maybe their top 10 plans that they end up exchanging members with, and so during your onboarding process, you can basically identify that and agree this is how we're going to tell you it's that particular payer. So there is coordination that's necessary in the front end, and that's where I think things like FAST and so forth starts to play in how do we implement this stuff at scale.
It'd be interesting to see how a national directory can really start to support that. I think that's a new endeavor, especially in a world where we've got a different paradigm than we've typically experienced under the HIPAA mandated standards. So we're moving into interoperability. There's a lot more, I think, complexities because of the way endpoints could be set up for API related exchanges and supports. So I think it's another example of some of the paradigm shifts that we're going through as we're modernizing our technologies and having our policy compliance fronts from our federal and state colleagues really move the needle forward. And I think that it's really great to see the number of folks on today's webinar and that we hope that they will certainly come back and engage in future sessions because I think we've all learned that interoperability is a team sport and it's a never-ending game. So I really want to thank Mark and Michael for their time today. And I also want to thank Denise and want to see if anybody has any parting words or thoughts from today's webinar that you might like to say as final words.
Comments on
I'm
the rule
always
are
up.
due June 15th.
Yeah, that's a good point. Yes,
Yeah.
I think one of the points that Denise made about the SFAT process. I think the comments we make on that are particularly important because I think we're going to see the need as the industry really implements this. That we'll want to see changes to some of these IGs, and that's where we really value the feedback from the industry. And so having the ability for us to be able to advance the IGs based upon real world experience is going to be important.
I agree with you. I think that, as much as HL7 FHIR community tests at connectathons and projects like Vinci are advancing real world piloting efforts, that there are things we're going to learn. And I think the version management is going to become a bigger issue for us all as we start to work more effectively between the CMS and ONC aspects of continuing to seesaw and leverage each other's authorities, and how we tap into establishing that floor and then building a future through SVAP that gives some innovators some chance to kick the tires, and then to see the subsequent policy upgrade to that policy floor is a new sort of paradigm for all of us to be living under. So I think it's been interesting to see some of the Da Vinci member conversations, as because we're all just really trying to make sure that we've got all the nuances of SVAP understood in the interplay that has happened so far. And I see that 0062, and I'd appreciate your thoughts on this, Denise. I think 0062 is trying to set a really clean floor for us to then build on as we move forward.
Yeah, and that's this concept of unexpired and expired IGs, and how do we sort of glide path to the most current, and then how do we advance the standard at a pace that's going to make sense for the community. And that's the one thing about open standards and working in the HL7 consensus process, is we have that opportunity for everybody to get involved, so that you can know where you're going before you get there. And then hopefully, if that SVAP process can really work with the organic timeline of that community process, we can move the standards forward in a really efficient way.
Yeah, and you also made me realize, Denise, that hopefully people know that as they're working with the implementation guides and experiencing an idea for a change or an enhancement, all you need to do is go to the bottom of that implementation guide and request a change in the footer. It'll take you to being able to submit a JIRA ticket, and that'll get you that input back into the community. And for implementation guide leads like Mark, they'll get those specific requests and for the applicable IGs, and we'll be able to bring it into a discussion focus with the participants on our use case calls. With that said, I realize we are at the bottom of the hour. I want to thank everybody for today's participation, for Casey as our moderator and Leslie for her support on getting all the messages out there. Folks can save the chat box or chat stream so that they can get easy access to those links. And we look forward to seeing you at our next community roundtable, which will be June 24th. Thanks, and have a great balance of your day.